Hello and welcome to the Multiple Sclerosis Association of America's live webinar, Women Living with MS. My name is Peter Demiri. I am the Vice President of Programs and Services for MSAA and your host for tonight's program. Tonight's webinar is part of MSAA's Women and MS campaign, which also featured a national survey back in July to learn how MS impacts women. I would like to take this opportunity to thank EMD Serono for supporting this survey and this webinar, which will unveil key findings and provide helpful strategies on improving MS management and achieving a better overall quality of life. I would also like to thank everyone who participated in the survey and contributed to the very important results that will be presented shortly. Next, I want to just briefly touch on MSAA and the services we provide. So, as many of you may know, MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. Listed here are just a few of our many free programs and services provided all across the country. I encourage you to visit our website or give us a call and learn more about our programs and services and ways we can help you better manage your MS. And lastly, tonight's webinar will be archived on our website within a week or so at mymsaa.org. As you're watching the program tonight, we encourage you to ask questions about the presentation by typing them into the chat box on your screen. We'll have a Q&A session at the end of the program and try to fit in as many as time will allow. Also, if you do have any technical issues with the webinar, please type those concerns into the chat box as well, and a moderator will reply to you. At this time, I am very honored to introduce our guest presenter, Dr. Annette Howard. Dr. Howard is a practicing neurologist and medical director of the Multiple Sclerosis Institute of Texas in Houston since 2001. She is a past MSAA board member and a current member of MSAA's Healthcare Advisory Council. Dr. Howard authored the Women and MS National Survey, analyzed and compiled the results, and is here with us tonight to report on the findings. She also recently hosted an MSAA Ask the Expert program on this very topic, which is now archived on MSAA's website within our My MSAA community platform. Dr. Howard, thank you so much for your work on the Women in MS survey and for being here with us tonight to present the results.
Well, let me say good evening and welcome to everyone. It is certainly my honor to spend this time with you discussing and teaching and helping to advance all of our knowledge regarding how women live with MS. Tonight's agenda will include a discussion about the national survey on women in MS that was recently completed, for which a lot of topics were under discussion, and these are a few, including the unmet needs in MS, fears of women living with MS, work, employment, and insurance, marriage, sexual function, pregnancy, parenting, and menopause, and then rounding out our discussion regarding the general health needs, along with talking about preventive health and empowerment strategies. I want to encourage you to write down your questions, and we will certainly try and get as many of them answered as possible. The Women Living with MS survey was done with over 1,600 participants, and they were 21% were under the age of 45 years, 58% were over the age of 45. 82% were Caucasian, and every state in the United States was represented. And our larger states certainly had more participation than our smaller states, but everyone was included. Now, as we think about the usual characteristics of multiple sclerosis, here are a couple of facts. It is now estimated that about 1 million persons are diagnosed with MS in the USA. And MS affects women 2 times to 3 times more than men, and usually the diagnosis is made between the ages of 20 and 40 years. In our survey, all patterns of MS were identified. That means the 4 most common types that include relapsing remitting MS, secondary progressive MS, primary progressive MS, and progressive with relapsing MS. All those 4 common types represent relapsing forms of MS. Our study participants felt by an amount of 77% that preventing MS relapses and progression were the most important issues to them. 70% of our participants are currently on a disease-modifying treatment. That includes our injectable medicines, our oral pills, and infusions. And 71% are receiving care from a multiple sclerosis center or a neurology specialist. Now, when it comes to the cost of living with MS, it is estimated that a total lifetime health care cost per person amounts to $4.1 million. That is a lot of money. However, we know that the vast majority of that is actually thinking of the cost associated with our disease-modifying treatments. In our survey, 46% had commercial or private insurance. 46% had public insurance, including Medicare, Medicaid, and TRICARE, and 2% have no insurance. Now, there are 2 important issues that come up when we're looking at the cost of health care in a patient that has MS. For us, we are very fortunate that the pharmaceutical companies will provide the disease-modifying treatments, that's what DMT is abbreviated, at a $0 copay. And there are also copay assistance programs. And some of you may be familiar with what they call foundation assistance. And this program, while being sponsored by the MSAA, has a wonderful MRI assistance program that can help with getting MRI scans of the brain and spine, and you can go to the website for further information regarding that. Now, when it comes to working with and living with MS, things have changed from the way they used to be. Back in the old days, when a woman was diagnosed with MS, she was told to quit her job and take care of herself. And luckily, we've advanced, and the American Disabilities Act has been very helpful in MS patients being able to stay in the workplace. And so patients now have a choice about whether to reveal that they have a diagnosis of MS or not. Now, things are also different in that it takes at least one working person to maintain a household. And so what I find is that people work more because they have to be able to put food and clothing and shelter and pay for those medicines than really whether they really want to or not. In our survey, 68% of the patients felt MS had a negative impact on their work and job performance. So that means that they thought MS was really affecting their work. And 23% of our participants wanted additional resources and support in either finding work or trying to be sure that they stayed in the work arena. Now, when it comes to whether you are able to stay in your job or to continue working, some of the reasons why patients quit their jobs is they're just not able to manage their symptoms and manage all the things that go with work. The very first bullet point is describing the three major issues that drive patients out of the workforce: overwhelming fatigue, cognitive issues that include memory, thinking, and concentration, and bladder dysfunction. And so that means it's critical to speak with your doctor or healthcare provider about ways in which you can manage these issues. And certainly there are medications that can help battle fatigue, help you to maintain your bladder, and to help that your cognition. There are also things that people need to help them get around in workplaces. I'm living in a place like Houston with a lot of tall buildings and places where you have to walk. And so while I know I'm speaking to a group of women where sometimes pride and vanity can get in the way, it is important to consider using assistive devices like canes and walkers and wheelchairs and scooters in order to help you get around and to get around safely and to be able to have some energy when you get to work. And so when I talk to patients about their jobs, I want to know things like, what time do you have to get up in the morning? What time do you have to get to work? What time do you get off? How far is your parking place from the building? How far is when you get in the building to get to your actually workstation? And so we may have to think of ways in which you can ask for certain kinds of accommodations that will help you be able to get to work and then do your job. Now, when it comes to whether you should tell somebody about your MS or not, I just talk to patients about, I think you ought to tell it before it gets out. And so for me, it would be important that I tell my story the way I want to tell it, and not to have it revealed when you are not ready for it. And so it's just the kind of thing that I think you ought to try and prepare for as much as possible. We also found during our survey that having MS and living with MS had a big impact on relationships. In the United States, we know that 50% of marriages will end in divorce. And when it came to our survey, almost half of our women who took the survey said that MS had a major impact in their own relationships. For the women who participated in the survey, 57% were married, and 18% said that they did not have no significant other in their lives. Now, sexual function. The very top bullet point gives us a wide variety of how many patients suffer from sexual dysfunction. 34 to 85% suffer from sexual dysfunction, and this is even known to affect young patients and newly diagnosed patients. And it's wise to note that the symptoms of sexual dysfunction can increase in significance or importance as you get older and as the MS may progress. And then we have a listing of some of the common kinds of sexual problems that patients experience: fatigue and decreased libido, lack of or reduced vaginal lubrication, sensory changes and difficulty obtaining orgasm, bladder and bowel dysfunction, weakness and spasticity, changing roles with your partner and cultural expectations, and MS-related emotional challenges such as grief, worry, and depression. Now let's look at some strategies for each one of them. And as I go these strategies describing some of these symptoms, you'll find that while they may relate to sexual dysfunction issues, they pretty much fall in line with the general symptoms that patients live with, and symptoms that can occur anywhere from the top of your head down to the tips of your toes. So when it comes to fatigue and decreased libido, I think that decreased sex drive, which is another way for naming libido, is really a result from being fatigued. And so you want to think about things that will help to conserve your energy. Planning to have sex when you've got energy instead of when you're at you're tired. Medications can help that. We prescribe Nuvigil or Provigil, dopamine, and some antidepressants. And the reason antidepressants are used is because they give a stimulatory effect in the body. Using sexual activities and positions that are less physically demanding, that means let your partner do some of the work sometime. Using adult videos and magazines that are appealing to women. So don't just go to the porn sites, because that may not excite you very much. But try and look for things that would be satisfying to you. Some patients have problems with sex because they have a lack of or reduced vaginal lubrication. They're dry. And so using water-soluble lubricants, prescription estrogen and progesterone suppositories, and even hormone replacement treatment can help with some of that dryness from an atrophying vagina. Sometimes people have discomfort that can include pain, numbness, tingling, and a difficulty in achieving orgasm. There are medications that can help with that. Using the category of medicines that we commonly use to treat seizures, including gabapentin, Tegretol, and amitriptyline. And specifically for orgasms, there are two medications, one flibanserin every night and bremelanotide, which is an injection right underneath the skin, subcutaneous, that you use 45 minutes before sex. And then there's the old-fashioned thing of communication, of exploring other ways to achieve sexual intimacy and satisfaction. Now, bladder and bowel dysfunction, sometimes women experience leakage and incontinence of both bladder and bowels, and we know that there are some medications called anticholinergics, which can help to hold bladders longer and allow you to hold them and not release them. I don't exactly recommend restricting fluid intake because we know MS patients don't drink enough fluids anyway. But sometimes you make that accommodation when you're trying to keep your bladder as empty as possible. Right before sex, be sure you empty your bladder and be sure you evacuate your bowels. And then just put some protective bed clothing there. For women, again, they're very sensitive about this kind of thing, but the male partners that I know of, they've admitted that it doesn't bother them at all, and they wish that it didn't bother you either. So please try to take advantage of some of these strategies. When it comes to weakness and spasticity of the legs, muscle relaxers such as baclofen and tizanidine can help, and then using different sexual positions. Now, when it comes to changing roles with your partner and cultural expectations, what I meant by that is that sometimes your sexual partner is your caretaker, and it's hard to separate out those roles. It's hard to think about taking care of providing for everybody's needs and then flip the switch and feel very sexual. So sometimes the sexual partner who's doing the caretaking has to get some help in doing some of those caretaking roles so that they can be reminded that they are the sexual partner as well. And then sometimes it's not all about sex. Really, people just want to feel close and that there's some reassurance and some education around just trying to be intimate and to get that good communication going. And then what about when you are suffering from grief or depression or worry, as can happen when you are living with a chronic disease? And then that's when you ought to do something about it. And so it may involve you taking medications like antidepressants or anxiolytics, or even considering some psychotherapy and some counseling. But the bottom line is do something, and because doing nothing is not acceptable here. What about the role that pregnancy can play in MS? Well, first of all, pregnancy is not a reason for you to not have, MS is not a reason for you to not have children. And as we can tell, even in our studies, that 70% of our study showed that these patients had children. Now, usually MS is beginning right when you are thinking about raising a family, having a career, and so 1/5 to 1/3 of women will even get pregnant after receiving the diagnosis. What we know about pregnancy is that you can have MS relapses, but our literature tells us that most pregnant patients have fewer relapses while they're pregnant. They can then increase right after you deliver the baby and then can decrease again 6 to 9 months after you have delivered. Now, patients now make decisions about breastfeeding. There are some studies that show that breastfeeding may be helpful in keeping your MS at bay, while some other studies say that breastfeeding is not helpful. So that's going to be a decision that you and your neurologist will have to consider as you make that decision. So what is it that we need to know about pregnancy? Well, most importantly, there's no FDA-approved disease-modifying treatment that you can take while you're pregnant. And I bet if I was face-to-face with you and I asked the question, when you were pregnant, what did your obstetrician allow you to take? And that everybody would raise their hand and say nothing, okay? And so it may not be exactly nothing, but there will be very few things that your obstetrician will say it's okay to take while pregnant. And so usually we want them to work with us, the neurologist, to be sure that we can manage your MS, particularly any symptoms you may experience, and yet maintain your and the baby's safety. I recommend that you continue to see your neurologist while you're pregnant so that the both of you can stay on top of any symptoms you're experiencing, particularly if you were to have some relapses, and that you'll be on top of the doctor's mind and you can be very closely followed. We are in agreement that any MS relapses should be treated while you are pregnant and in some form of steroids depending on how severe your symptoms are. We encourage you to do some form of exercise, and usually we ask that you start the exercise regimen before you're pregnant and just you can continue it on according to your level of comfort. The one thing I like to advise my patients is we want you to get pregnant when your MS is stable. So that means we do a pre-pregnancy evaluation, especially updating your MRI scans, and we want to be sure that you are stable before we stop and discontinue your disease-modifying treatment. And then we can make a plan for how long it is that you should, how long you can wait without being on any medication. But what I tell people is if we're going to plan it, that's the best way we can do this is a planned pregnancy. And then as soon as we stop that medicine, I tell everybody, get busy and hurry up and get pregnant. So what kind of fears did we uncover during this Women Living with MS survey? Well, as you would expect, it's a very common fear that you are worried about how your MS is going to do, especially the older that you get. And because these concerns sometimes go along with your ability to work, there's some concern about how long or how will I be able to stay as I am, especially physically and cognitively? How long will I be able to work? And what will I do if I'm not able to work? And then dovetailing into that is financial planning. How do you plan for a future that is unpredictable? Whatever it is that you do, I just encourage patients to try and maintain a good quality of life. If you're going to plan your children, plan a family, let's plan it especially during periods of stability with your MS. And then some of the other concerns and fears that patients had was how sometimes they reported difficulty in how they did in their relationships, and certainly coming up with other medical conditions was important, because we know that MS patients have MS, but especially as they get older, they can have other medical conditions as well. So it's about looking at the entirety of you, looking at you as a whole person, and patients were as concerned about it as those of us who manage patients on a day-to-day basis. Now, what about if you have a family and raising your family? 70% of the women in the survey had children, and 92% of those patients who didn't have children said MS wasn't the reason that they didn't have any children. 8% of those said MS did affect their decision to have children, and they were concerned about having MS, getting older, and trying to raise children at the same time. They were worried about affording children, worried about during the pregnancy and delivery, what if there were complications. Some people stated they had a fear of getting off of their disease-modifying treatment and the effect it might have on their MS. And then we hear this a lot, is what is the possibility of passing MS on to my children? And for all the lack of really good information that we have stated in the past about answering that particular concern, I found two things that might make it simpler to understand. First of all, you have a greater fear of passing on those kinds of conditions that run in families, like high blood pressure, diabetes, cholesterol. But when it comes to MS, that the average person has a 1 in 750 chance that they will get MS. So that's considered rare. And then what if you already have MS and you're wondering if you perhaps are a parent or a sibling, then what's the chance that someone else in your family will get it? So you have up to a 1 in 20 chance of being diagnosed with MS if your parent or a sibling has it. And so I think these are two statistics that will help us to have a better grasp on answering that question than we have had previously. Now, what about the older woman that is living with MS? Well, we know at some point each one of us will go through menopause. And so in countries like the United States, the mean or the average age of menopause is between 49 and 52 years old. And so when we talk about perimenopausal, that's the years leading up to menopause, and then postmenopausal, that's the years after menopause has set in. These are the common symptoms. Well, of course you know that you have the loss of fertility, but that doesn't mean that it can't happen. You heard of what's called those change of life babies? This is a time when it comes. The most common symptom is hot flashes. This is where the dry and atrophied vagina comes in and why it can be painful to have sex. Those psychological symptoms, they call them mood swings. And then there is the lack of estrogen may result in osteoporosis, for which bone fractures might be possible. So what is the relationship between menopause and MS? Because frequently when a woman becomes perimenopausal and menopausal, they'll start to get worried about, my MS seems to really be acting up. And then they wonder, is this symptom because of menopause or is it because of MS? Here we have a report that 40 to 54% of women believe that their MS symptoms get worse when they go through menopause. And what we find is the same symptoms that you live with MS can overlap with symptoms that you can have because of menopause. And they are fatigue, bladder problems, where you might have leakage and incontinence, constipation, diarrhea, irritable bowel syndrome, cognitive issues, becoming forgetful, having memory problems, problems thinking and maintaining your concentration. Then there are those vasomotor symptoms that give you those hot and cold flashes. Depression, anxiety, irritability, again, those mood changes and fluctuations. Sexual dysfunction, sleep disturbance, usually insomnia because of the hot flashes. And then there can be pain syndromes. And so it's important to discuss with your neurologist about what your symptoms are and to try to make that distinction. And so when patients present to me with symptoms like this and they are going through menopause, then I recommend that they see the gynecologist and talk about a treatment or treatments for the menopausal symptoms. And usually when you take a treatment for the menopausal symptoms, it becomes clearer what's menopause and what's due to MS. And patients usually can get back to their previous baseline and feel like they know the difference between the two. Now this slide is describing the 5 major areas that the women in our survey felt where they needed support the most. Here is financial security, and that then goes back to whether you're able to stay in the workplace and then whether you feel like you have enough resources to take care of you as you begin to age and while your MS may be progressing. Relationships, either in marriage or with significant others, was another area where patients needed support. Certainly navigating all of the workplace issues, including any necessary accommodations or, trying to stay in the workplace or even leave the workplace, patients needed more advice on. Parenting, especially as you live with MS and trying to then still be a full-time good parent was also another area of need. And then relationships with family was also recognized as an important need, because not everyone in your family can appreciate that you are living with a chronic illness that may make it difficult to do certain things in life. And so figuring out how to communicate with family issues about your wants and your needs and your areas of support. The statistic that we gathered from this discussion where support was needed, the patients reported in the survey that 51% of them didn't talk to anybody about these particular needs. And so that's why it's an unmet need. And we're going to try to be to address how patients can get the necessary support to manage what they have decided is important to them. So when we get to what else can happen and how you can maintain a healthy, quality life with MS, it gets to preventive health. And what we found is that MS patients, especially those who were more physically affected, did not meet the usual, normal, healthy targets of doing their yearly and annual screenings. So people are not getting their preventive health screenings. And so we recognize that the neurologist sometimes for MS patients is the only doctor or the doctor seeing the most. And so we have to be sure to add it to our list to say, you know, are you seeing a primary care doctor or a gynecologist about getting your annual well-woman visits that will include mammograms and pelvic exams? Certainly if you're a young mother and you're still breastfeeding, that you're getting the supply, support, and counseling that you need. If you are a woman in childbearing age, are you getting contraceptive counseling because you want to plan your family as best as possible when you have MS so that you can be healthy and so can the baby while you live with the MS. And so the following is a listing of some of the common things that you should be screened for on an annual basis. Getting blood pressure checks, getting your cholesterol checked, looking at your sugars and screening you for diabetes, and also getting a thyroid check, both by blood work and thyroid, because thyroid is the most common disease that women who are between the ages of 20 and 50 can get. And then if you're sexually active and perhaps not in a committed relationship, you want to get some sexually transmitted disease screening, which includes HIV and HPV. That's human papilloma virus. And certainly if you're less than 35 years old, your primary doctor may want to talk to you about the HPV vaccines. And then as you get to a certain age, usually 50 and older, you may want to do certain cancer screenings, particularly gynecologic cancers and colon. And so there's a lot that we need to do in order to just try and remain healthy as you are also living with MS. Don't make any assumptions that while you're doing everything that you possibly can for your MS, don't leave the other parts of your body unattended to. So what do you do in order to try to stay on top of this ever-growing level of of understanding that we need in order to live our best lives with MS? Well, one, you have to understand that you have to continually grow your education curve. You can't get everything at the doctor's office, and so in between those visits, you're going to have to do some things on your own. I find that the MSAA is a great place because they have webinars and video libraries and lots of publications and articles that can help you try to stay on top and continually to learn and grow your education curve. Our survey said that 57% of the people in the survey didn't talk to anybody about their MS and general health, and that they relied on themselves. Some of them got the information from the neurologist or other healthcare providers that they used, and then they relied on a support network, which might include other MS patients and family members or even people who participate in a chat room. Here again, as we begin to summarize, is a review of some of the unmet needs that were found out and addressed in the survey. And so planning for the future financially and physically was very important. Continuing to do the best in raising families and children, as well as trying to stay in the workplace, was important. Staying healthy physically and mentally was important to patients, especially as they got older and with aging. Patients were concerned about how to manage their MS symptoms, as well as health concerns only that women would experience. And then lastly, trying to maintain good relationships with others. Now, I want to round out this discussion by talking about what we call the MS Toolkit, because MS can feel like work sometimes. And so if we're going to think about working with our MS, well, we want to put tools inside our toolkit that will help us to do the job as best as possible. And so the most important thing that goes in your MS toolkit is your disease-modifying treatment. And I want to speak to your taking your DMT as prescribed and not as you feel, and being sure that you are monitored carefully with blood work and any other testing to be sure that your DMT is effective for you. What would you do goes inside the toolkit if you have an MS relapse, your treatments for your MS symptoms that you live with on a day-to-day basis, scheduling your annual MRI scans of the brain and spine to be sure that there are no new lesions, and what is the plan for if something goes wrong with your MS or if there's a medical emergency. And what I mean is, are you supposed to call the doctor? Are you supposed to go to the emergency room? Just knowing what you're supposed to do. And then the last thing in the toolkit is being sure you have a support team. Somebody in your corner who can help you to stay on top of your MS and who you can call and be there of help to you if something were to go wrong. And the last thing that I'd like to share with you this evening before we take some questions is how to live an empowered life with MS. And the most important thing about being empowered is to know that you are educated and you can advocate for yourself. Take all your medicines and vitamins as prescribed. While no one can live a life free of stress, try and minimize the stress you have on a day-to-day basis. I recommend my patients to join a support group so you can be in it with somebody else who knows exactly what it's like to live with MS on a day-to-day basis. When you seek out your healthcare professionals, I want you to ask questions and be sure you get the answers. Tell the doctor, hold up, stop, write it down for me, say it again, spell it, but be sure you get the answers you need. While there's no specific MS diet, it's recommended that you eat healthy. That means fruits, vegetables, chicken, fish, not a lot of red meat, and drinking water. Regular exercise, doing something that you would like to do, and you can do it on a regular basis. We don't like to see people smoke cigarettes at all, and we want you to limit your alcohol to what is considered not excessive and not too much. And with that, what we can expect to happen in the year 2020 is that we think 3 new medicines may come to the market for MS. 2 will be pills, and 1 will be an injection underneath the skin. There will be continued to be what's called post-marketing studies, continuing to look at the current disease-modifying treatments that we have and being sure that they are effective, and then monitoring their safety. And we're going to look at medicines that are already out there for use with other conditions and seeing how they can be helpful in managing your MS symptoms. And with that, Pete, I think I'll turn it over to you, and we can be ready to answer some questions.
Great. Thank you, Dr. Howard. Boy, that was an excellent presentation. Discussed a lot of the data from the survey and certainly gave a lot of insights and some great suggestions on how to manage MS. So thank you for that. We did have quite a number of questions that came in, and I'll get to as many as I can as the time allows. One question dealt with menopause. It said, because I am very heat sensitive due to my MS, does that mean I'll have even worse hot flashes during menopause than other women who don't have MS? And if so, what can I do about that?
Okay, that is an excellent question. And so here's the bad news. The bad news is that your heat sensitivity may worsen because of hot flashes. But here's the good news, that there are treatments that can help that. So that's a good way to go and speak with your gynecologist about managing your menopausal symptoms, and that should help so that your heat sensitivity is not as significant.
Okay, thank you. There were several questions that came in around cognition. And in particular, people wanted to know some practical ways or suggestions to help improve or manage their cognition.
Okay. When we look at cognition, we are thinking about memory, thinking, and concentration. And we commonly find that MS patients are forgetful and have problems finding the right word, and sometimes processing information, knowing what they want to say but not being able to get it out. And there are some relationships to those difficulties that we can sometimes see on your MRI scans. When we look down in the middle of the brain, on that side view, the corpus callosum, which is a band of tissue that connects the left with the right halves of the brain, can sometimes be thinner than it is expected. And that can clue us in as to what kind of difficulties you are having cognitively. We can treat cognitive issues with the same medications used to treat Alzheimer's disease, like Namenda or Aricept. We may add the medicines for fatigue, because sometimes you can't think because you're tired. Sometimes we use antidepressants because, again, of the stimulatory effect, and if you got more energy, you can also think better. And believe it or not, this is anecdotal experience, but Ampura has been known to help people's cognitive skills be improved. They have sharper thinking with that medicine as well.
Okay, thank you for that. Question around pregnancy. If you're not supposed to be on an MS therapy during pregnancy, can you resume treatment after childbirth? And if so, how long after?
Well, that's going to be a decision between you and your neurologist, and it may have to do with what your MS was like before you were pregnant. How did the pregnancy go? How did the delivery go? That will then tell you what you need to do afterwards. I think that, I guess in my practice, let me speak to my practice, most of my patients decide to get back on their disease-modifying treatments right after delivery. And for some of them, they take them right on to the hospital with them, or they start them a few days afterwards. If you're going to decide to breastfeed, then again, you and your doctor need to decide how long you might do that. Both of you can decide how comfortable you might be going without medications. The first 3 months after delivery are probably the most vulnerable for having an MS relapse. And so, you have to keep that in mind when you make that decision about how long you're going to stay off of the medication.
Okay, great response. There were a couple questions around complementary or alternative medicines, holistic medicines, and in particular, if you had any experience with patients using CBC oil for MS-related issues.
Okay. I know that patients are using something like CBD oil, and they have told me that they are helping with some of their symptoms. I don't really have a problem with what else you do, but I'm a real hard person when it comes to taking the medications needed, like your disease-modifying treatment. And so I think the jury is still out on how well something like CBD oil really helps MS symptoms. I personally don't have enough knowledge or experience to advise patients on whether that would be helpful or not. But what I am skilled at is knowing what FDA-approved medications can help with symptoms patients live with. And so I'm certainly prepared to offer patients something for practically any symptom they have, but, again, it's their choice about any alternative therapies.
Okay, thank you. The question on contraception. I noticed that once I stopped taking birth control pills, my MS signs and symptoms presented itself. Is there a connection?
There may be, and certainly there are several popular studies in the role that estrogen may play in MS, particularly when you're between the ages of 20 and 40. And so certainly sometimes contraceptive, particularly birth control pills, help to stabilize some of what goes on during the usual menstrual cycle. And so, believe it or not, having a lighter flow can be helpful as compared to a heavier flow. Not experiencing cramps and nausea and headaches can be helpful in keeping your MS at bay. And so, it might be something just to keep in mind. And while you may not need the contraceptive part so much, you may want to think about continuing it if your gynecologist believes that it would not be harmful to you.
Okay, thank you. There was a question about what you had mentioned earlier in your presentation about people with MS not taking much water that they should. So someone asked, why is that, and how much water is recommended per day?
Okay. You ever heard anybody say a lot of water is enough water? Well, MS patients tend to drink less because about 75% of MS patients have problems with their bladder, and they have problems holding their bladder. And so if you ever seen that commercial where the lady was gotta go, gotta go, gotta go, well, that's the fear, having urgency, meaning you gotta go, and frequency, knowing where every bathroom is. And so as is human nature, when you have a problem with urgency and frequency, then you're going to limit how much you drink. And so that's why, as a result of not drinking enough fluids and water, MS patients commonly have urinary tract infections because they're not taking enough fluids in to be able to flush that bladder out. And so that's why I don't like to recommend restricting your fluid intake, but, you know, you got to make a choice. Sometimes when it can be an issue doing sexual relations.
Okay, thank you for that. And our last question, and it's timely as we start heading into fall and then the winter time, is the flu shot recommended for MS patients?
Yes. The two most commonly recommended vaccinations include flu and pneumonia. And so we certainly recommend that. Now, there are some times, depending on, there are probably two medications that you want to time when you get your vaccinations, and that would be around your 6-month Ocrevus infusion. You want to be sure you get your flu and pneumonia shots, 6 to 8 weeks before your 6-month infusion. And when you're getting Lemtrada, you want to get your vaccinations again, 6 to 8 months before your Lemtrada infusion, or 6 to 8 weeks after your Lemtrada infusion. And then I also recommend separating the flu and pneumonia vaccines by 2 weeks. You don't want to get them at the same time, left arm, right arm. You want to put some time in between them so that your body is not reacting to two things that your MS may say, wait, there's something new here, and then have some sort of reactivation of your MS symptoms.
Okay, well, that's great advice, and thank you so much for those questions on those answers. They were, or answers on those questions. They were excellent. Well, we've reached the end of our program tonight, and I want to thank once again Dr. Howard for her excellent presentation and all this very important research and very helpful insights on ways to better manage and live with MS. I also want to thank EMD Serono for supporting the Women in MS initiative, which included the national survey and tonight's webinar. Speaking of which, we should have tonight's webinar archived on our website at mymsaa.org within a few days. So please visit our site and look for the posting in our video section. And as we end tonight, I invite you to take a very brief survey coming up next that will give us valuable feedback on this program and other webinar topics you would like us to do in the future. So on behalf of MSAA, Dr. Howard, and everyone watching, thank you so much and have a great night.